like you to join us for our first plenary of the day. From data to action, leveraging artificial intelligence and real-world evidence for informed priority setting. And I would like to invite a person who may be able to answer your question about the song. She is the program director and senior researcher at HITAP. She is also affiliated scientist at St. Michael's Hospital and an associate professor at the Institute of Health Policy, Management and Evaluation at the University of Toronto in Canada. Ladies and gentlemen, please help me welcome the session's moderator, Associate Professor Wanrudee Isaranuwatchai.
63 years ago, the world have met a new singer, went by the name 7094. Yes, it was a computer. It was the first time that a computer sang a song to us. And it picked that song, Decibel. Fast forward to today, 2024, it's relative. Brother and sister have do so much more. No longer just singing a song, writing a song perhaps, writing manuscript, that is a topic that we can discuss more, driving a car, playing chess, or even passing the Alan Turing test, and even perhaps writing a speech. Though I can guarantee with you, not this one, or else it will be a lot better. So in this session, we are going to take a look how far we have come. What is it that AI can do to support our healthcare system? But AI has a partner in crime. It can get better with one thing, and that's not human being. Well, although we are needed, we hope. But it needs data. So in addition to learning more about how AI can help us, we will also learn about data and AI, how we can drive those data and AI to support priority setting, a topic which I believe all of us here hold very close to our heart as we gather here today. So as mentioned, my name is Wanrudee, and I would also like to welcome all of you to our home here in Thailand. And it is certainly a privilege to be a moderator for this plenary. We have an amazing lineup, and yes, I am biased. As I've been working with other speakers, we have an amazing lineup with 4 speakers. 2 will focus on data, 2 will focus on AI, with the focus of sharing with you example from the real world of how people have used data and AI to help support policy-making process. Now, each speaker will have about 10 to 15 minutes, and we will open up for Q&A. Now, you could ask your questions. I'm asking you could ask your question at the designated microphone stand. You can also send your question through the Steven app under the live Q&A for plenary 1 as well. And yes, of course, you can ask AI. What question should be asked in this plenary? But please be kind to the speakers. So without further ado, it's my privilege to welcome the first speakers, Dr. Jasmine Pu, who is the CEO for the Data Science Center at the Fujian Catholic University in Taiwan. She will be sharing with us on the topic of exploring the potential of RWE in policy making. Case study from Taiwan. Dr. Jasmine, the floor is yours. Thank you very much.
Thank you for the kind introduction. As a person who majored in public health and epidemiology and then later learned economic evaluation, master's and PhD degrees, I have feeling at home in this conference. So I will begin this plenary session by introducing some work of my previous work. Okay. So for starting 2017, I have been involved in the National Hepatitis C Elimination Program. This program is started with the acknowledgement of the direct acting antiviral agents. It's a cure medicine for hepatitis C, which was a quite serious problem in Taiwan. And this poster shows our government. The right-hand side was our health minister back then, and the vice president in the left hand. So the government decided we have this vision, we have this goal to reach hepatitis C elimination by 2025. So how do we do that? This drug, this medicine is quite expensive. We have quite some patients waiting to be treated using this medicine. So the resource allocation was not easy in the government perspective, but how we have a strategy to finish this very important task is another question. So that's how we started to use real-world evidence to help the policy-making process. So aligned with WHO Global Health Sector Strategy published in 2015 or 16, I could not remember now. But the strategy, the strategic direction would be like this, 5. So basically, we would like to know who, where, what, how, and financing in the future. So we actually did a lot around these 6 questions. But for the time's sake, I will just showing you several of this strategy plotting process. So for the first question, who? So we use a lot of earlier studies to identify in Taiwan, there would be geographic variation of our patients because in early days, some areas with limited access to healthcare, they got infected of the virus. And they are also, because of this reason, so there are cohort difference. Those who born before 1970s are with more higher prevalence. And the high-risk population in Taiwan would be like this. So this, we started using data to understand who. And in order for central government to collaborate with the local health bureaus, that we started to make this map, high-risk map, to help the local government to acknowledge their challenges and also help the resource allocation, so to prioritize the resource spending. So in the initiation of this program, we don't have the national anti-HCV status. So we use 7 proxy index to build up, to draw this map that will be done on the left-hand side. So in the beginning, because the local government didn't know what we're going to do with this data, so that was drawn based on fewer data. And then of the first version comes out and then understand why we are doing this. So they filled in us to with more data, so that's the second version. And after several years, maybe 4 or 5 years of implementation of this program, now we got representative national-wise anti-HCV data. So this is that's our third map. So how do the local bureau, for example, when the first version map comes out, the news press had released this map. And there was a city, their local bureau, they telephone me and say, why do you just release this? Our local legislator just calling in to express their concerns of why they are living in high-risk areas. So I think this is a good strategy for identifying where to start. And then we have this patient registry for those receive the National Health Insurance reimbursement of DAA. Building up this registry, we've been able to routinely follow up the real-world effectiveness of the DAAs. So this shows till 2021. Of course, they are still collecting the data, still publishing the data. But using this, we understand, okay, the decision of use this DAA was not that bad because the cure rate, SVR12, is indicates of cure. So cure rate is very good. And but we would like to know what happened if there are some systematic error or something. Then we follow the missing results. What are the reasons? So basically, we use this patient registry, also used as a MEA, management entry agreement, simply saying that if SVR12 yes, the patient cure, the NHIA will pay to the hospitals. If the negative results, they will not pay. Will go to pay to the hospital, but company will pay back to the NHIA. If there are missing data, means the hospital didn't do enough job to call back the patients to get the results done, and then they would not pay to the hospital. So when I was the director, and I have this worry in the very beginning is that the real world, because the RCT is one arm RCT, so it shows 95% to 98% of efficacy. But what if the real world effectiveness is not as good as RCT? When is the time that we should cut it off? So how good is good? How bad is a red flag for stopping this is another worry. I think the lesson I learned is that in Taiwan, the platform, the channel, the IT is ready for out there, but the policy analysis needs talented team to do all this planning and monitoring. So we actually got this data, routinely follow up from the screening rate, confirmation rate, and the treatment rate. So we would like to really want it to be accomplished. One thing we use this thinking is in the beginning there were some signals for safety issue. In our office, we routinely got all these system reports, and if there are signals, we will pass it to our clinical team, and we will have feedback to the system. But the thing that we find out is that when there are safety signals and our TFDA thinking about changing label decisions, they are reluctant to use real-world evidence. Back then, they are more confident to use the traditional way they are thinking about decisions. So how when there are RCT, real world evidence, or PK data, how should we do it? So I think nowadays it's not the way we use data as early days that we only use RCT. It's rather how we think about the relevant, what is the enough evidence for that decision under that context. There comes our second example is in Taiwan. It's immuno-oncology, immuno checkpoint inhibitors reimbursed. A registry also built up just like DAA registry, but they use this very easy, simple calculation and do some hard decision. They cancel the patients with liver cancer and gastric cancer because it seems lower among these patients. So are these really enough to do delisting decisions? We have these earlier experiences that we use the claims data set to compare the bare metal stents and drug-eluting stents. And we found it is not enough. Even we do this beautiful survival analysis, but we don't know the baseline status of the patients. So although we do observe there are differences in real life effectiveness, but we are, as we see it, is not enough to do some delisting or further decision just on these evidences. So again, all these experiences lead me to think about when should we lose the requirement of evidence? When should we really hold on the RCT thinking, or sometimes we can confidently use real-world evidence? So, these are the lessons that I learned from the examples. Because of the time, I will not say one by one. Just I think you got the idea. So I will jump to this. We have this working together to build up this realized guidance to help us to handle the real-world evidence more confidently. So in summary, I think the importance of real-world evidence is increasing for policy making, but it needs the capacity to identify what data is needed in certain context. As I am promoting the idea now in Taiwan that it should be admissible evidence from appropriate methods under due process, and that's what we need. And we also need more dialogue among the stakeholders to address the challenges and the need for capacity building. Thank you so much. These are my, that concludes my talk. Thank you.
So certainly from National Hepatitis C program to support manage entry agreement to things like reassessment of previous decision, real-world evidence may not be a magic bullet, but it certainly can be helpful. Next, you may recall James Bond once has a theme, the world is not enough. Now, today, we will have our version of that, talking about when unreal world evidence is not enough. So, by day, he is the professor and chief of the Division of Health Policy and Management at the Department of Public Health Sciences at the University of California, Davis. Now, by night, he is our very own version of James Bond on the topic of real-world evidence for informed funding decision. When is unreal-world evidence not enough? Please help me welcome our 007, Professor Hoch.
Wow, it's sort of hard to follow up based on that introduction. But I really would like to start by thanking the conference organizers and also thanking Dr. Wanrudee Isaranuwatchai for her leadership in putting together today's session. My name's Jeffrey Hoch, and I'm a professor of health economics at the University of California, Davis. Davis is a small city in Northern California, and today I'm going to be talking to you about two experiences I had that made me believe that real-world evidence or real-world data might be pretty useful. You may draw different conclusions, but I want to share with you what I've been through. I'm also going to tell you a little bit about AI because that's part of today's session. So I've learned that AI can be useful when you want to make a talk, for example. You can type in a very useful prompt here. I don't know if you can see it at the top, but AI is kind of a thing. It could catch on. And wouldn't it be neat if we could somehow combine real-world data, real-world evidence with AI? So let me give you the stories about my experiences that made me believe real-world evidence or real-world data could be useful. And then perhaps we can have a discussion about how we can integrate AI if you do believe that these things could be useful. So let me start with the lessons from my experiences first. When people talk about real-world evidence, I find it's really important to try to understand what do they mean by that? Are they asking you how many people are actually going to use this product or intervention? Let's say it might involve some risk, or it's only given at highly specialized centers. It's possible they just want to know if we funded this, how many people would actually use it? In particular, how much money would it cost? Maybe instead people are worried about adverse events or harms, and that's what they want with their real-world evidence. Perhaps they're interested in costs or even outcomes, and if they are interested in outcomes, which outcomes? As a health economist, I think everything should be about cost effectiveness, but it's possible they want outcomes that are different from QALYs. It's possible there are outcomes that speak to them. So as we consider real-world data and real-world evidence, it's possible that what we want may not be easily collectible, and we might need to consider, is it a priority to do a really good job collecting what we really want, or perhaps it might be worth it to do something that we can get quicker and might be close enough. When you have the data, you might be thinking about how you want to analyze it. Radical idea might be thinking about what analysis do we want to do, and then thinking about what data we need to do that. These are some of the lessons that I learned. Something else that started to occur to me later on in my career is, I wonder what decision that this is going to actually inform. Yes, as academics, we would love to publish these results, but if you wanted to have more than just brushes with relevance, if you wanted to actually inform a decision, potentially we might want to do the analysis that's actually going to affect a decision. If there is no off-ramp for defunding something, perhaps there's not a huge thirst for information about whether it's cost-effective after it's already being paid for. So these were some ideas that occurred to me while I was contemplating the lessons that I'm about to share with you. The first lesson happened when I was developing and directing the Pharmacoeconomics Research Unit for the largest province in Canada, in Ontario. We were supposed to help decision makers use and understand cost-effectiveness analysis, and one of the highest priorities they had for their decision recommendation group was that they use evidence. Raise your hand if you're against evidence. Tough crowd. Yeah, so evidence is great, right? You know, who would not want to stick by the evidence? It's like the best thing, and we're all good people for it, right? Well, occasionally, there are some challenges that we face, like this lady here. She's a young mother. She has 2 children. Unfortunately, she also has breast cancer. But the cancer in her breast is smaller than 1 centimeter. And the evidence that we had, based on the trial that was done, was for women who had tumors greater than 1 centimeter. So of course the committee wants to be a good recommendation committee, and I'm not going to tell you the name of the drug, but it rhymes with Herceptin. But you can't make me tell you the name. So the committee that's evaluating this drug is going to do the best they can all of the evidence is for women who have tumors greater than 1 centimeter. And I like the way this is written. It says the members had little choice. I mean, I was there was no threat of violence. It was just an agreement that the priority was going to be, we're going to stick with the evidence. And the evidence was very inconvenient. This seemed like a good thing for people who had larger tumors. However, when you get to the real world, you meet people who don't fit into those criteria. So what are you going to do with your conflicting priorities? You're going to tell her, the lady who has access to social media, the newspaper, and the TV, about your strong belief and your priorities about evidence? And what precedent might this set if you decide to fund beyond the evidence? It was this experience that led me to believe that maybe collecting real-world data might be a good thing. But it also started to make me think, well, what are we going to use it for? Her doctor seemed to believe that there was no reason to believe tumors that were smaller would react differently from tumors that were larger. Another oncologist was worried that she might experience adverse events that were seen in the trial. So, as an academic, I'm really interested in what the truth is. But if I were a policymaker, I might be interested in trying to solve a problem. This was a challenge that made me believe real-world data might be a way to get around this, might be a way for us to get the evidence that we needed. The second experience I had was when I went to the US. I was recruited from where I was in Canada to the University of California at Davis, and I thought it'd be fun to continue this health technology assessment thing. So I volunteered to serve on the California Technology Assessment Forum, CTAF. CTAF is one of the recommendation panels that is run by the Institute for Clinical and Effectiveness Review, or ICER. They're the folks who are doing health technology assessment in the United States. We had the opportunity to review a drug for Alzheimer's disease. And as I learned more about this to get ready for our vote, where we were going to vote, is this a low value, a medium value, or a high value drug? I learned that the FDA in the United States, they're the folks who decide whether the drug is safe and effective to sell in the US. They had been looking at this drug, and their expert review panel had decided that this was not a good drug to recommend. They weren't actually sure that it worked, but the FDA thought a little differently. The FDA thought perhaps this would be something that they should recommend. So let us say that their expert panel was nonplussed about that decision, and 3 members resigned. And we had the opportunity now to vote on whether this was low, moderate, or high value. Wouldn't it be nice to see if in the real world we saw people getting better? This would be an opportunity for real-world evidence or real-world data to inform, better calibrate our decision. So after this experience, I also thought, wouldn't it be great to be able to see what the truth was, to see what the data were telling us when this is actually used in the real world? In terms of setting things up for the future, I believe that we need to think about how the results are going to be used. It doesn't make a lot of sense to collect information that is actually not going to inform a decision that's not going to be taken. If we can decide on what information we want to collect, it would be really great if our analysis actually answered that question. If the concern is about adverse events, because those are the ones that likely appear in the newspaper, then asking me what I want for cost-effectiveness analysis, it makes me happy, just not a good use of resources, because what the decision makers care about is perhaps adverse events. So figuring out what is the question we're trying to answer could help us do a more efficient job at the real-world data we're going to collect. AI may not be able to tell us what we should be thinking, but it might be able to help us find the best way to inform our thinking. Last but not least, we'll be hearing from 2 other speakers about the role of AI, and I'll be listening for how I can use what they're about to tell us to do a better job with real-world evidence. So let me summarize what I think are the messages I'd like to leave you with. I do believe we can do a better job at priority setting if we have better information. I also believe that real-world evidence can provide better information, but there are some trade-offs. Last but not least, I believe processes are needed to both create and use the evidence. For example, going back to cost-effectiveness analysis, if there is no off-ramp to funding a new product or drug, collecting more information that suggests that this might not be a wise use of resources might be greeted with a small degree of resistance. So it's possible that if we could co-create so that the people we are hoping to inform have a say in the information that we'll be giving them and its utility, perhaps we'll be more successful in this regard.
Thank you very much, Dr. Hoch. So we are saying that real-world evidence can be enough by saying that unreal-world evidence may not be enough. Loving the double negative there, certainly waking us up. But truly, thank you for the future direction, highlighting the importance of process, including talking about having a clear question, because I don't think it's just important for real-world data, likely for research and priority setting overall. So with your link to AI, we're now going to shift gear. After we hear a lot about the data part now, how about let's hear some example about all the cool things, not driving a car or making a speech. Again, AI didn't help me this one. But like what can AI really help us do in our healthcare system? And with that, we're going to turn to our next speaker, who is an expert in AI. Dr. Wenjia is from the National University of Singapore, and she will now share with us a number of exciting case study that on the use of AI in real world. Sorry, that did not go according to plan. Thank you. Wow. I don't think that's AI. That's our very experienced organizer in the back. Now that I mentioned them, perhaps please give a round of applause to RP Media in the back. Wouldn't it be nice in every presentation you have a group of people making all the technical problem go away just like that? Okay, so sorry. Back to Dr. Wenjia. She's from the National University of Singapore. So please help me welcome Dr. Wenjia.
Thanks, Wanrudee, for the kind introduction. I am Wenjia Chen from National University of Singapore. I'm a health economist and outcomes researcher who has a lot of interest in AI, but not yet an AI expert. So today I'm going to walk you through a few exciting examples of clinical AI use in real-world settings. Let's see if I can. Okay, so having heard about the bright potential and progress of real-world evidence, it makes me realize that we are at a critical moment that we can combine big data, AI technology with public health, which has the potential to transform the future landscape of healthcare paradigm. AI is not a single technology, but rather it's a collection of different diverse technologies that has imminent relevance to the field of healthcare. Machine learning is the most typical type of AI, which which fits the model in the data and learn by training the model in the data. It evolves from simple supervised learning to neural network that reason between input and output by weighting the factors that associate the input and output, to deep learning, which can be simply seen as many levels or layers of neural network. So by learning the data, especially real-world data, machine learning enables the accurate prediction of clinical risks and treatment effects, to enable precision medicine approaches, and also enable the detection and analysis of cancerous lesions for image diagnostics. There are also other type of AI like that make sense of languages and create conversational AI, transcribe patients' conversations and learn unstructured clinical notes. There are like if-else, rule-based expert system to maintain the data set, real-world data set. And there are also like a physical robotics, like surgical robots, and process that automate the repetitive digital tasks called robotic process automation. So these type of AI technologies can be used in combination or separately, and they greatly empower the medical diagnostics and treatment and engage patient in the process of self-management and also assist in the healthcare administrative processes. But I would like to remind the audience that every year there are many AI-empowered health technologies that has been invented and tested, but only very few of them have been really clinically implemented and evaluated for public access. So to prioritize the appropriate AI-empowered health technologies to be used in the public, these technologies need to undergo regulation. And the regulation is typically managed by public health agencies and treated the AI-empowered health technologies as other digital health products, as medical products, typically under the medical device category. And the main focus of regulation is centered around patient safety, human safety, data security, as well as the performance, whether these type of technology really works. Currently, there are very few countries in the world, except for some advanced Western markets, that will have reimbursement scheme for AI-empowered health technologies. And for these products to be reimbursed in these markets, it typically needs at least some type of clinical evidence. But economic evidence is really scarce, and the methods for evaluating AI algorithm itself, rather than AI algorithm coupled with a medical device, it remains quite unclear. And as part of the regulatory process, once it launched to the market, AI technologies still need to undergo like a post-marketing surveillance and continuing to collect real-world evidence for surveillance and update. Okay, so in the next 7 minutes or so, I'd like to discuss about a few examples, very exciting examples of AI application in healthcare, which have been all approved and reimbursed in certain countries. The first one is called the HeartFlow FFRCT, which is a non-invasive imaging diagnostic tool that helps diagnose coronary artery diseases. When physician sees a disease, the physician can send the patient to receive a coronary CT scan, and the image will be uploaded to the HeartFlow app. That AI algorithm, together with computational dynamic fluids, can help create the individualized 3D color-coded 3D models so that the physicians can see the functional information of each blockage, like the narrowing of the arteries and how it affects the blood flow. By this way, it prevents a lot of unnecessary invasive testing as well as the radiation exposure. And there are evidence from a large body of patients in England showing that, as I circle here, in the cumulative incidence of mortality plots, that with the addition of the HeartFlow analysis to the CT images, it can effectively reduce the all-cause and cardiovascular mortality. And there are also economic evidence showing that, at least in UK, the addition of the HeartFlow analysis to CT scan doesn't cost a lot of incremental costs. It's less than £50 per patient. And in fact, this app is considered cost saving. There are other type of digital diagnostic tools like Synapses for diagnosing the eye problems, and Qmetrics for diagnosing the mammographies. The second type of AI application is to support precision medicine. There are many cancer drugs in the market, and this app called CureMatch is a clinical decision support platform that helps oncologists to identify and design the best combination cancer drug treatment that tailor to the unique needs of their patients. So the overall process is that once the molecular profiles of the patient has been created and uploaded to the app, this app will perform machine learning to learn the patient's genetic information and compare with the information that they store in their big databases to rank the top personalized treatment, combination treatment that is considered most effective for the patients. So the physician can review this report and make personalized recommendations on the combination treatment. And it will also help to better stratify patient population for more efficient clinical trial designs. And there are evidence from more than 700 patients with diverse cancer that for those patients, as shown in the green line of the survival curve, for the patients whose treatment regimen is more than 50% matched by as ranked by the QMatch app, they will enjoy a better survival. And they will have a higher proportion of people who experience remission as well. And there are other type of precision medicine AI apps, such as Cancer IQ, that screens the risk of people's cancer risk based on family history and genetic information. And there are other type of app, OncoBox and Tempus. The third type of AI application in healthcare is to enable disease self-management. For example, this DBLG1 system developed by Diabetes Loop is it's a CE-marked medical device that meets Europe's product standards, and it helps with the self-management of type 1 diabetes by three components. So it's a medical device that is composed of an AI algorithm embedded in a handset, such as a cell phone. And the cell phone is connected to a continuous glucose monitor and an insulin pump. So for every 5 minutes, a glucose measurement is done, and the AI algorithm receives the real-time data, and it will analyze the real-time data together, like a glucose level, together with meal exercise and disease history, to make recommendation whether to maintain the current settings or adjust, or even stop the insulin delivery, or deliver a bolus to correct a high. So there are also clinical evidence showing that by using the DBLG1 system, like immediately or like at least 2 weeks, within 2 weeks of its use, it will be able to help the majority of patients to remain at a desirable range of glucose level, which is between 70 to 180. There are other type of these type of app, such as the MyCOPD, that analyze the current symptom to make a recommendation of medication use. The fourth type of application is to enable population-level risk monitoring. So as funded by AI Singapore's Grand Challenge, an elite researcher team in Singapore, it strives to develop a national primary care model called AI-assisted 3H, hyperlipidemia, hypoglycemia, and hypertension care. So it collects this system is aiming to be used for the major healthcare settings in Singapore, that it can collect data from patients routinely, like collectible data, and such as from health screening kiosks, to profile, risk stratify these potential patients of, based on their risk of developing cardiovascular diseases and the complication of cardiovascular diseases. And it will be linked to some intervention strategies based both on individual level and group level. And it also has a human-machine interface that can guide the users through their mobile phones and link them up for assessment and interventions. And the last example is surgical robots that you must be very familiar with, such as the Da Vinci surgical system, that can help the physicians to perform surgery with enhanced visualization and more precise instrumentation and minimally invasive techniques. Although there is insufficient evidence to demonstrate the superiority of robotic surgery, it could be confounded by the operator's experiences, but the benefits are very obvious here. So I'm running out of time, and I just want to conclude here that AI-empowered health technologies has a bright potential to revolutionize healthcare. It can enhance the efficiency of risk prevention, of diagnosis and treatment outcomes, and it can streamline and enhance the healthcare delivery process. But currently, there are a lot of challenges in implementing AI-empowered health technologies on a population level, because there is a general lack of AI-specific or digital health-specific regulation process worldwide, needless to say the reimbursement schemes. And the real-world data or evidence on the effectiveness and economic impact of AI products that has been used in healthcare has not been sufficient. So a few potential solutions to fully harness the benefit of AI will include the enhanced regularization and standardized assessment of these type of technologies, like HTA reference cases, and the continuous generation of real-world evidence and collaborative partnerships. So thank you, and I think we can welcome the next speaker, Dr. Karthik, to dig deeper into how to implement and develop and implement the AI applications. Thank you.
May I ask all the speakers to join us on the stage? We have 13 minutes and 24 seconds left. And it wouldn't sound very good if we were to say that we have prioritized your questions based on what our session coordinator, a researcher from HITAP, Hi Pichari, who is very busy in the back, or me. So let's just say we ask AI to help prioritize the question. So if your question is not chosen or picked, please get mad at AI and not us. All right, so jumping right to the first question. A huge problem with evidence is, are we sure all circumstances, oh no, the question disappeared. Okay. We sure all circumstances are represented in the evidence. Lack of evidence may mean a negative result in a study, but it also may mean that there's no study done yet, and those should become a research priority. Thank you very much, Professor Wanrudee. That's a very, very good point. So I'm throwing over to our speaker. Anybody would like to take that first? There are 4 of you. We cannot ask AI to answer. But everybody have the mic? Okay. Yeah. Yes, please, Dr. Hodge.
Okay, so it sounds to me like the question is about when you either have bad evidence or no evidence, does it mean that we should actually study whatever we have bad evidence or no evidence about more? From a health economics perspective, I would recommend from the textbook, if the benefits of studying it outweigh the costs, then maybe that makes a lot of sense. So sometimes when we waste people's time making the economic models, one of the biggest benefits that come out of it is A, understanding what's unknown, but B, understanding which of the unknowns seem to affect the conclusion, and which of the unknowns are unknown and really don't really affect the conclusion. So my advice as someone in the business of making models would be, use a model that would tell you this would be a high priority thing to learn more about because it'll give you the most information that you may find useful in making a decision.
Thank you very much, Dr. Hodge. Now, we also are accepting questions at the microphone as well. So first we'll go to the gentleman right over here. If you can introduce yourself to us, that would be great too. Thank you.
Sure. Harald Schmidt, University of Pennsylvania. I'm asking an old school question in the flesh. I tried to navigate the app, but it's too complicated.
No worry.
I have a question for the last speaker on the comparison to mammography screening, which I understand is a helpful reference point, but even in mammography screening, we have very high rates of false positives, overdiagnosis, and overtreatment. You flagged that the sensitivity was higher on the AI amplified version. So I was curious if you looked at that too, because it raises both questions about preference sensitivity, or the ethical need to respect the preference sensitivity of this decision to be screened, as well as the cost effectiveness of the intervention, right? So finding more cases doesn't necessarily mean averting more deaths, but may well mean we're doing more, not necessarily for good outcomes, right? We may have more women who get screened unnecessarily, and that's not necessarily a good thing. So curious if you could comment on that. And then just a question about possible conflicts of interest. There were a lot of products mentioned in this session, and I was a little puzzled that there was no declarations. If maybe each of the speakers could just comment if there's anything we should know. Thank you.
Cool. So I'll probably first start with the conflict of interest part. The product that I talked about, I'm not associated with them within the board. It's essentially been a product that came to me as government. So essentially, there's of course an entire scientific committee that evaluated it, and I kind of thought that this will be a good use case, a case study to talk about how does real world decision making happen, sometimes way away from what the textbook would talk about, and also understanding the context. So interestingly, one has been trained to kind of think about mammograms as mammography as almost like a gold standard. But the most important thing here was understanding the context. The context being that setting up a mammography unit in a low resource setting is extremely expensive. 1. 2, you wouldn't even get technicians to actually interpret them. 3, it's also very difficult to actually run and maintain the mammography unit in extremely far-flung areas. So the context was the one which took the priority here, where we had to look into identifying solutions that would work in extremely far-off areas, in rural areas where probably there is no technician to even travel. So very often, and therefore the decision was biased more towards understanding the context and understanding the user experience, and not so much about the science part. Mm-hmm. The clear evidence of comparing and understanding that there could be a lot of false negatives with either of them. So the goal was use science, but also use a lot of context to drive the decision.
Thank you very much, Dr. Karthik. Now, in terms of the COI question for the other product, would you like to?
Yeah, I have no conflict of interest in any of the product that I mentioned. They are all reimbursed and approved in different markets, and I just came across them by random.
Yeah, thank you.
So sort of randomness.
And
I do have conflict of interest. I get paid by ICER for the work I do for ICER when we're doing health technology assessment.
But ICER is not an incremental cost effectiveness ratio, but ICER is an
Institute for Clinical and Economic Review.
And they're public.
Oh yeah, you can watch it on YouTube if you're having trouble sleeping.
That's actually not a joke.
We're not recording this, are we?
We can deduct after, yes. Dr. Jasmine, any?
I don't think I mentioned any product names, but I was presenting today. All of them are from public sectors and from my earlier governmental and HTA experiences.
Yeah. Thank you. All right. Thank you very much. So the next question that got the most votes is data and AI often are under control of resource-rich groups, and that they can make health system more inequitable. How priorities community, like here, can help prevent this inequity and support vulnerable to gain benefit of this investment? Thank you very much, Professor Yot, for a great question. Over to the speaker, please. Yeah. That's the sound of the AI starting. Yes, please, okay. Dr. Jasmine.
I think it's time for HTA to help because when the government, I think either high-income country or low-middle-income country are welcoming AI products or AI algorithm helping in the healthcare sector. Like in Taiwan, we are truly welcoming this while our National Health Insurance or our Ministry of Health and Welfare don't know what are really valuable and don't know what if it's really beneficial to the population. So I think it is time for health technology assessment help to identify the real value and also make sure we use the cost effectiveness and affordability taking into account into the process.
Thank you. Any other speaker would like to add something to that? No? Yes, please.
It seems like if we're going to want to study things with data, then the people we're going to want to study need to be included in the data. And if that's not a priority for the people who put the people in the data, then perhaps we need a better marketing campaign about expressing our values and then making the case that the benefits of doing that outweigh the costs. I wish there were a way to show that.
Yeah. All right. Yes. So thank you very much. Now, moving on to the question by Professor Huy Lin from National University of Singapore. There was a question, but it disappeared again on my phone. And I think the question was around reassessment. But the question may be more specific to Dr. Karthik in terms of how often should we think about re-evaluation, given that program algorithm get updated all the time. But if I may actually share the question to other speakers as well, because how often really when we talk about real world data, every day things are moving forward, things are changing. So how often should this intervention, this analysis be re-evaluated? Over to you.
Wow, this is a great question. Not that I know everything about it, because what I typically do is only take most of my machine learning algorithms right from the lab to the clinic. But then this was a very interesting one where how do you take it now from the clinic to the real world? Now, essentially, the broad way I think about this is just like how we would take drugs before we ingest a pill, we go through a variety of clinical trials, both for safety and efficacy. I think we would want to use the same kind of analog for machine learning as well. So you would want to, the essential process is, first, can we stay first on safety? So is our algorithm safe for human usage? So how do we use a variety of user-centered trials? How do we do a variety of clinical trials to first ensure that the algorithm is safe? So I think a lot of evaluation needs to be first done, focused on patient safety first, and then comes effectiveness at a later stage. So, so in terms of how often, I don't think we know enough about it, but the goal is the evaluation has to truly match what we want the algorithm to truly accomplish. So one of the key questions that we would want to ask any AI ML application that comes to the real world is how often has it been evaluated? What were the outcomes on which it was evaluated? And what is the settings in which it was evaluated? I think if we can just ask these three broad questions, I think that should be a good way to go forward.
Other, please. Re-evaluation of the analysis and doesn't just need to be the AI part, but in terms of the intervention.
I will talk from HAP-C example. I think in the beginning we spent some time to try to understand the whole picture of the product, of our patients, of our community, including the delivery process and things like that. So I think in the beginning we will have an idea what we are going to have. And with the routinely, for the registry, we routinely try to maintain a monthly report to really look at the data. And we will spot some signal for something terrible might happen. So that's what we do without the AR part. I think if we do it this all again, I think AI could help after we identify what are the really signals for real evaluation. We can really use that to help us to alert us what should be should be re-evaluation at this moment.
Thank you. All right. First, next, maybe I should declare what I'm about to say. So I have direct conflict interest as I'm part of the scientific committee who have influenced the agenda today. But we have an amazing agenda for you later today. So we are going to finish this session on time. But one final thing to all speakers, just one word. Okay, one word that comes to your mind when you think about the potential that data AI can help support priority setting. What is that one word?
Probably not a word, but enough to say that there's a lot of AI applications that are well researched but not implemented, and a lot of AI applications that get implemented but don't have adequate evidence.
I think it's risky.
Something positive, Dr. Hoch?
Yes.
Not no.
Cost saving.
Okay. All right, ladies and gentlemen, please help me thank all the speakers for this session.